I've been talking here and I'm muted. Can you see my screen?
Yep.
Yes.
All right, let's start with lupus. This is a systemic connective tissue disorder. It is autoimmune. Because it's a connective tissue disorder, it's going to be multi-system as far as the damage goes. It will affect each and every connective tissue. Now, name one system in the body that does not have a connective tissue.
Can't do it.
There aren't any.
I'm sorry.
There aren't any.
All right, that's the answer. There aren't any. Each and every organ, every system in the body has connective tissue. I mean, it's just impossible to hold the human body together without connective tissues. So each organ has connective tissue parts. Let's take the kidney, for instance. So the kidney has a parenchyma, where the nephrons are located. No, that's the functional part. But in order to hold the whole thing together, you need connective tissue. And I can say the same for the liver, the heart, the lungs, the brain, all your GI organs. The blood itself actually is considered a connective tissue. So your bone marrow, everything has connective tissue. So there are two forms. You have a discoid, which is not systemic. Discoid only affects the skin because the skin is a connective tissue. So that is the mild form of the disease, the discoid type. But the more common type is the systemic one, which is debilitating. This is a lifelong illness. You can only control it, but because of the treatment, which is immunosuppression, because this is an autoimmune disease, the patient will most likely have exacerbations. One such exacerbation is triggered by an infection. The patient gets sick. Of course, they'll get sick because they're taking immunosuppressants. As far as incidence goes, more women are affected compared to men. And the age group are childbearing years, so that's between 20 and 40 years of age, which is where you guys fall under. You are in the childbearing age group. It has also been linked with other problems. So on top of lupus, because it's a autoimmune disorder, so you develop one, you most likely will develop another autoimmune disorder. So on top of that, they may have Raynaud's phenomenon, right? And then all other complications stemming either from the disease or from the treatment. We just concluded treatment for Addison's disease and Cushing's disease as well. So you know that after we did surgery, the patient will now be taking hormones for life, correct? So the patient will be on corticosteroids, which is what these patients will be on as well. So they'll suffer those same complications related to the corticosteroid treatment. So here are our triggering factors. Sun exposure is the most common. So this is the non-infectious trigger. I mean, it depends also on where you live. Oh, I know someone who was in Florida. She has lupus, so she had to move somewhere cold. And of course, there's no place where you don't have sun, but at least she can protect herself from the sun. She goes out. She never goes out without an umbrella, for instance, or at least a large hat when she's outdoors. Yeah, she's just taking precautions. But the move, I guess, worked for her because she's usually on social media telling us if she's in the hospital. So she hasn't said anything like that. So I guess the move was good. We have an entire table for the manifestations. Look at table 19.8. Generally, the patient, because again, the red blood cells, the blood is considered connective tissue. So on top of that, the patient may have anemia. So that will lead to fatigue. They have a low-grade fever. In the skin manifestations, they have what's called a butterfly rash. In the discoid type of lupus, which is affecting only the skin, this will be their only manifestation, or the rash as well. But the SLE type has everything. So they have alopecia, photosensitivity, um, ulcers. Okay, and then ulcers not only on the skin, in the fingers, but also inside the mouth, in the nose, and even in the perineal area. The most common complaint is pain. Their joints, because they have connective tissue there. However, to distinguish this from arthritis, there is no synovitis here because it's only the capsule around the joint that is really inflamed, that's causing the joint pain. So when they move, it rubs against that capsule, causing the pain. So that's why when these patients have exacerbations, they're pretty much bedbound. They cannot move because of the extreme pain they feel with moving any joint. I mean, not just the knee, but the hip, the hands. It's a debilitating disease. You've heard about, who's that young chick that has had lupus, that had a transplant? Selena Gomez. Okay, so she has lupus, and she ended up losing her kidneys. This is the common complication of lupus, called lupus nephritis. They end up losing their kidneys, so they go into CKD and therefore will require dialysis, if not renal transplant. Neuro, because you have your meninges are considered connective tissue, so the patient will have these complications here for neuro and cardiovascular. You learned last semester when we talked about pericarditis that lupus was one of the causes, along with an MI and infectious causes. Pulmonary, you'll have pleural effusion because the pleura is a connective tissue. Patient may also have pneumonitis. The eyes, you'll have lesions. The frequent complaint are dry eyes. And blood, of course, I already mentioned anemia, thrombocytopenia, and as well as leukopenia. So these patients will have all three. So is it fun having lupus? Not at all. All right. So it's not this one to get. You're guaranteed to be, you're guaranteed you will be disabled here. You may be able to manage the disease and manage to do work, but you will have some long-term disability, which is expected of the disease once you have a flare-up. Look at the triggering factors that cause an exacerbation. Pregnancy, because you are childbearing age. Exposure to the sun. You're not gonna be able to wrap yourself in bandages and look like a mummy, right? So chances are you will have sunlight exposure. You get sick. Again, the treatment for the disease to keep you in check, meaning the management of the disease involves immunomodulators, which are, unlike steroids though, which are non-cell specific. Some of the immunomodulators that these patients will be taking are more cell specific, meaning it doesn't necessarily have to suppress all the cytokines that trigger the immune system, okay, which is which is better than taking steroids, which have pretty much a shotgun effect, which will suppress everything. Surgery, or even silica dust, or some medication allergy. So pretty much any substance or factor that will trigger your immune system will cause a flare-up. Management will be all right. So as far as diagnostic testing is concerned, it's not that easy to diagnose lupus because the manifestations are the same as rheumatoid arthritis or the same as systemic sclerosis as well. It's not and there's no test that will rule out SLE itself, meaning it may take years before you're actually diagnosed, and you may be treated for another disorder before the doctor actually comes to a conclusion that you have lupus. Okay, let's take for example the ANA, anti-nuclear antibody. This one, as stated here, does not confirm the diagnosis because ANA is also positive in rheumatoid arthritis. I mean, you looked at it last semester, right? We covered rheumatoid arthritis last semester. The RA patient also had a positive ANA, and other autoimmune disorders are also positive for ANA. So there's really no one specific test. So it's all a matter of we rule out other causes first. Let's say this one will cause pancytopenia, correct? The doctor may opt to, let's say, get a sample of your bone marrow. They'll perform a bone marrow aspiration and biopsy to see if it is, not some form of cancer, for instance, that's causing the pancytopenia. So it's the tests done here are more done so that we can rule out other potential causes. So when we rule out other causes, then we're left with lupus. Treatment. First, because the sunlight exposure there was our common trigger, so therefore the first one is to protect your skin from the sun. So your sunscreen must be SPF 50 at least or higher. Well-balanced diet, that's good for anything. Regular exercise, and then in between you have to do rest periods. Of course, you can't do rigorous exercises here as a prevention because remember, the patient has fatigue already to begin with. When you overexert yourself, that might become a trigger for an exacerbation. We can skip the radiograph. Again, these are not used to diagnose the patient, but rather to either rule out the other causes or to check for complications of the disease. For instance, we know that this causes kidney failure, correct? So we can check the kidneys, especially during an exacerbation. We can check chest x-ray to see if there's any pneumonia or pneumonitis developing, or any pericarditis or pleural effusion or pericardial effusion that may be accumulating in the pericardium. Here's the painful part. We have a lot of drugs for this patient, and all of them are testable. First, the famous hydroxychloroquine. This is what Trump has been touting for COVID-19. This is a common treatment for lupus as well as rheumatoid arthritis. So particularly for lupus, this seems to block the effect of ultraviolet rays when exposed to the sun. So of course, when every time this patient goes out, they are at risk for a flare-up, right? Because they're exposed to the sun. So taking Plaquenil will lessen the effects of the sun. But you've heard, right, that hydroxychloroquine has cardiac dysrhythmias as the common side effect. So the patient therefore will have to be checked regularly for those complications as well. So here, this hydroxychloroquine, again, there's no cure, okay? This is important to remember. For lupus, these medications they're taking are just simply to decrease the number of flare-ups or exacerbations that they will have, meaning they're all symptomatic. There is no cure for lupus, as with any other autoimmune disorders. We currently don't have any. So hydroxychloroquine or Plaquenil, specifically to target these, the skin and joint manifestations. So prevent here, as I said, prevent disease flares and serious organ damage, as well specifically kidney damage. And these are your common side effects: abdominal pain, nausea, but those are the mild side effects. Nsaids will be given for pain. So when these patients have the joint pains, the abdominal pain, they'll be given ibuprofen, not opioids, because the pain here is inflammatory in nature. So therefore, it makes sense that you give anti-inflammatory analgesics. Steroids will be given during an exacerbation, though. We routinely do not give steroids every day for these patients. The reason is, I mean, you just looked at the effects of steroids in the last module. So this can cause Cushing's syndrome, correct? Plus puts the patient at risk for infection compared to other immunosuppressive agents, because glucocorticoids they broadly inhibit cytokines, meaning they're unlike certain medications, which we'll cover next on table 1911. The other immunosuppressive agents target only specific cytokines that cause inflammation, which contributes to the symptoms of both RA and lupus. Okay, so it's better to use those instead. That way you're not suppressing all of the cytokines that are responsible for triggering or stimulating your immune system. Okay, so meaning to a certain extent you can still protect yourself from infections, unlike steroids, which inhibits all of them. So one such immunosuppressive agent, which is specific, methotrexate, for instance, only targets tumor necrosis factor, which is the number one cytokine responsible for the symptoms of RA and lupus. So the joint pain here and inflammation caused by tumor necrosis factor is suppressed by methotrexate. This is a biologic response modifier. Sounds very expensive. So this is also used for or specific also for this one, whatever this is. I don't know what that is, but that is what's being inhibited by belimumab. And here is a summary of our medication. So we discussed Nsaids already for pain. Steroids, again, take note, this is, well, if it's low dose steroids, this can be given for a maybe every day, as long as it's only in small doses. But the high dose steroids are only reserved for flare-ups, when the patient is admitted in the hospital and gets an exacerbation, meaning they have these symptoms right here. They have the kidney failure, they have pneumonitis, or they have the blood disorders flaring up, then they'll be put on high-dose steroids. The topical ones, clobetasol, this is just an ointment, okay, given for the ulcers. And these are the rest of your immunosuppressive agents. So we discussed methotrexate, azathioprine, and cyclophosphamide. These are considered calcineurin inhibitors. Actually, all three. Here we have azathioprine, mycophenolate, cyclophosphamide. So the acronym there is PsycMyAz. Okay, so I hope that will help you remember. These three are calcineurin inhibitors. They only target interleukin 2, I think. I think they are they target interleukin 2, which is one specific cytokine that will trigger specific lymphocytes that cause these symptoms right here, the lupus nephritis and the CNS, as well as the pulmonary, the pneumonitis. Okay, so these drugs will only target that specific cytokine. The patient will only be on one of these. Okay, you can't give all 5 of these because they, especially these 3, because these fall on the same drug group, drug class. They're all calcineurin inhibitors. So whichever, I guess, the patient has the least side effects with, or maybe it could be also the patient's insurance. As far as I know, the cheapest one is mycophenolate, and this is also used for organ rejection as well. And in fact, all 3 are given for as treatment for acute organ rejection. I won't test belimumab because not all patients are on this. It still remains a very expensive treatment. Questions so far for drug treatment? Dora?
No questions.
All right. Complications. So the most serious here are your heart and kidney and lung as well. So we have lupus nephritis, we have pneumonitis, as well as pericarditis are your most serious complications. Here's a drug alert for Plaquenil. So you need a baseline eye exam here because it can cause retinal damage, retinal toxicity. So they have to be done before we start treatment, and then onwards while you're on Plaquenil, you have to have a regular eye exam. And we already know this from the pain chapter last semester. We discussed what were those 3 complications arising from Nsaids again. Because these are chronic NSAID users. So lupus and rheumatoid arthritis patients are the ones that really take NSAIDs every single day.
Gastric bleeding.
Gastric ulcer.
Okay. Sir, and then bleeding.
Ulcer.
What else? So here, renal impairment. And what is the third one?
Headache.
When is NSAIDs contraindicated in patients who have what disease?
I know this one.
Come on, I see it's on the tip of your tongue. Show me your tongue.
It is.
Chronic kidney disease.
Well, we have renal impairment already. It has something to do with prostaglandin.
Yes.
No.
So here, it's the same thing.
Peptic ulcer disease?
Sorry?
Peptic ulcer disease?
No, we already said that.
Oh, we said that.
Pregnant patient?
Yeah.
What was that, Linda? Oh, was that Linda?
It was
Professor.
Hello?
What about cardiac patients?
Okay, that's it.
hypertension.
So if the patient has a cardiac history, we should not be using NSAIDs on those patients because that will actually, there's evidence now growing that it has led to cardiac mortality, especially if the patient had cardiac surgery, meaning they had heart bypass. So that means the patient has severe coronary artery disease, and it's the same really. It's because the drug inhibits prostaglandin, which is a vasodilator, and we need that for um, blood flow to the nephrons, which are tiny. And the same thing, if you inhibit prostaglandins, it also damages those goblet cells in the GI tract. That's why there is um, those goblet cells that produce mucus will now have poor blood flow because you're taking NSAIDs, so therefore less mucosal production to protect the stomach. So therefore it exposed to acids, it breaks down, you get peptic ulcer, and then you get bleeding. And the same thing here, prostaglandins are necessary for the coronary artery perfusion. So if you inhibit that, so therefore it also contributes to cardiac mortality.
Professor,
Yes, go ahead.
yeah, but we give aspirin to people with AFib, no?
I'm sorry?
Aspirin. We give to people with AFib.
I can't hear you, Gladys. Sorry.
You cannot hear me?
Not clearly.
Oh.
It's like you're eating gum or something.
No, I'm not
Something
eating
in
He
your
said aspirin to patients who have cardiac issues. We give them aspirin as a preventative.
Oh, yeah. No
Atrial
problem.
fibrillation.
Now, aspirin is not an it's not the NSAIDs that they're talking about here. Okay, these are the ibuprofen, because aspirin has a different mechanism of action. It does not inhibit prostaglandin.
But it
This
is
is a
NSAID.
salicylate. I'm sorry?
It is a group of in NSAID.
Yeah, but it has a different action though. It does not inhibit prostaglandin synthesis.
Oh,
It has a completely different action.
okay.
Okay. Here's a summary for nursing care. These are now your patient's manifestations.
Professor,
Yeah.
can I ask you a question? Patients with lupus, are they allowed to have children?
Yes, absolutely. But remember, pregnancy is a trigger for an exacerbation, right?
Right. So what would they like? What would happen if they are pregnant and they do have lupus? Like, are there other ways to care for those patients during pregnancy, or like, is it even safe for them to be pregnant?
Very good question. Is it safe for them to get pregnant? The answer is no. But if it happens, I mean, it happens. You know, they got pregnant. So what can we do now? So it's all a matter of balancing now. If they get a exacerbation during pregnancy, then they get hospitalized, and we just, you know, make sure the baby stays fine. There's a chance they might lose the pregnancy. All we do is just to lessen the impact of, because it is a trigger. Okay, it
Right.
is a triggering factor for an exacerbation, a flare-up. We can't plan pregnancy around, you know, the cold winter months. So let's say, because we know heat and sunlight exposure is a trigger, right? So you have now two triggers. So maybe we can plan pregnancy in the cold months, maybe conceive around August, which is the last hot month. So so if you conceive there, that means you will when will you give birth? So yeah, you should still be winter, at least the end of winter by the time you give birth, right? So let's say you get pregnant at August. So September, October, November, December, January, February, March, April. Yeah, that will be, you'll have to conceive earlier than August, maybe around end of June or July, because technically, you know, you won't have any symptoms of the pregnancy there yet. So it can be done. Okay, so we'll just choose drugs that won't
Harm the baby.
the placenta, right? So yes, they can. I know somebody actually who had 4 children
With lupus?
Yeah, yes, she had 4 children.
And she survived?
Yeah, last time I checked, she was alive.
It's I don't
And
know, because
children are grown.
It seems like lupus is like very devastating disease, like an autoimmune disease, and there's so many complications from it. So I don't know, like
But
it's crazy.
yeah, these people can, if you manage it correctly, you stay away from, sick people, avoid getting sick, pretty much do what we're doing now for to avoid getting COVID-19. So if you're just careful like that, yeah, you can, you're okay. I mean, look at Selena Gomez. She has lupus.
Yeah, but
She's
she also has a lot of money, Professor. That's the difference.
Professor, is the disease
well,
genetic?
that doesn't really mean, that much, because it's still a matter of how you know,
Take
how
care
you
of your
conduct yourself, right? No
yeah.
matter how much money you have, if you're out there clubbing all the time, I mean, you will get sick.
Yeah, that's also true. Well, that's good to know, though. I didn't know. I was always wondering about that. Can they live like a full life? That was my question. But
Yeah, just make sure you wash your hands, wipe from back to front, stay away from um, crowds. Although it's hard with somebody else's lifestyle, but for regular people like you and me, I mean, I could probably do that.
Professor,
yeah,
is the disease genetic?
Say again.
Is it genetic?
No. Autoimmune disorders, no. But there is a tendency though, like if a family member has an autoimmune disease, meaning it's not passed on from mother to child or something like that. It's just that if you have an autoimmune disease, most likely someone else in the family may have it too, because you have pretty much the same genes, if that makes sense.
Yeah.
But there's no guarantee that everybody will have lupus, because again, it's not or here exact etiology is really unknown. We don't know. We just assume it's autoimmune, because we don't know what else it is. Plus, based on the symptoms, it's all affecting or caused by our cytokines. So that's why it could be autoimmune, but there's really no evidence that it's genetic or um, runs in the family.
Okay.
So all your management here is drug therapy, and it's all about keeping your patients safe while on these treatments, and of course, monitoring them for the complications, mainly kidney, lung, and cardiac complications, which are your most serious. And with regards to drug treatment, it'll be the same. So later when we talk about organ transplant and organ rejection, the because we're using exactly the same medications, so therefore, our nursing care will be the same. Our nursing teaching will be the same. Avoid crowds, wash your hands, monitor your um, temperature often, right? Um, practice good hygiene, eat healthy, things your mom would say, right? Surgical management. This is not, again, a cure for lupus. This is just to manage the complications. So most people, for those who work in dialysis here, or if you know
I
someone
do.
okay, so
I do.
you have patients who have lupus,
Yes, I've had a couple of patients who had
right?
lupus.
Yeah. So on top of diabetes, hypertension,
Pension, yeah.
yeah, some people who are in dialysis clinics have lupus, and that's what caused their CKD or ESKD. And that's it for lupus. Any questions? Please read the rest, okay, under nursing care. They are, especially the rationales here, why you take them that. I mean, why you teach them that. All right, so here's the sunscreen. Um, Fatigue, again, this is caused by anemia. Obviously, they can't get live vaccines because of the immunosuppression. Now, the immunosuppression here is because of the medications, right? But remember, they naturally have neutropenia because of the disease, because there's connective tissue also in your bone marrow. Here's oral OCPs. Now, don't take this as they can't take OCPs. Okay, in fact, this is one of the teachings that they try to avoid pregnancy, especially that would end up having to carry the pregnancy over the hot summer months. Okay, so we do encourage OCPs. All this is saying is, if the patient has migraine headaches, Raynaud's phenomenon, blah blah blah, then you should not take OCPs. Is that clear?
Yes.
Okay, because the rationale here, it will increase their tendency for blood clots. They will develop DVTs if they have these disorders here. Alrighty. And yes, they would benefit from a skin specialist also for the, you are childbearing age after all, especially if you're still single. Okay, so you may want to take care of your skin, okay, so that you remain attractive, and you'll find that someone easier, okay, if you don't have the butterfly rash, because that's scary. All right, let's go to eight. Forgot the page. 808. Okay, yeah, 808. This is another autoimmune disorder. I guess we will cover organ transplants next week. So this will be our last topic for today. Guillain-Barré syndrome. This is not a primary disorder. This always results from something else, meaning this is rather a complication of something. What it is it results in an ascending motor paralysis. So the rationale here is there's an acute inflammatory demyelinating polyneuropathy, meaning it involves demyelinization. It's not exactly the same as multiple sclerosis. This one is triggered by usually a viral infection, okay, wherein your patient develops a demyelinating form of polyneuropathy, meaning inflammation sets in and causes the demyelinization. In multiple sclerosis, you only had patches of demyelinization, meaning in between the, let's say this whole statement here, this one is one length of your muscle, right? And then all along there inside we have nerves, correct? So the demyelinization here in Guillain-Barré is involving this entire length of your neurons, whereas in multiple sclerosis, it may only be these conjunctions here. So you have demyelinization there, demyelinization here, demyelinization here, and here. So the demyelinization is in patches, meaning the impulses can still travel, but they're just interrupted in between. So that's why in multiple sclerosis, they can move, they can still move. However, is their movement smooth though?
No, it isn't.
Yeah, not small. Yeah, they'll have maybe shaking. Yeah, they'll have shaking. They'll have the purposeful, the key feature in multiple sclerosis is they have tremors during purposeful movement, meaning when they intend to do something, they have the tremors. The tremors are caused by the patchy demyelinization. Okay, so in certain parts along that muscle, you have missing myelin because you have developed antibodies against the myelin, but it doesn't destroy the whole myelin sheet. In Guillain-Barré, it involves the entire length of the of a series of nerves. That's why the paralysis is ascending. For some reason, it starts from the feet, from the legs, and then goes up. This is and it's always bilateral. It's not just involving one leg. It's always both legs going up, and it'll be both knees and so on. So let's look at the trigger. So how do you get Guillain-Barré? The most common cause is Campylobacter infection. Others are cytomegalovirus, Epstein-Barr, so that's mono. Then we have the flu, either the flu or a flu vaccination has also been documented as a prior trigger. I've only seen one Guillain-Barré patient. It was actually two now. Well, I only took care of one. He was a Saudi national. I mean, like you and me, all he had the flu 2 weeks ago. And then next thing he knew, he got up one day and then he fell because he couldn't support his weight. Okay, so so it's like him, just dangling his feet and then got up and then fell because he could not move his feet. And then upon admission, the weakness just progressively went up. First thing he couldn't move his feet, and then now it was his legs and then his thighs, and then after that he was already intubated because it reached his diaphragm. So that is the pattern of the disease. The other person I knew was actually an instructor here for Swedish. You weren't here yet. She was here with us around 2016, I think, was when she left. Yeah, about 4 years ago now. She had weakness, same pattern. She was out in the yard, and then she kept falling a few times, and then the next day she couldn't get out of bed anymore. And then of course she's an RN, so she knew the symptoms, so she went to the hospital right away. But for other people, patients may wait because they don't recognize the symptoms. They'll just say, oh, maybe I'm just tired, and then wait too long before seeking help. So those are the people who, I mean, you can recover from this because it's not really, look at this, it doesn't have a high mortality, see, 2 to 10%. So it's not really a fatal disorder, and you do recover, especially if you reach, if you seek treatment early, specifically within the first 2 weeks of the onset of symptoms. The sooner you go, then we can give you treatment. This is considered a autoimmune disorder, and so we can suppress the immune system. We give you immunoglobulin infusions, expensive but very effective. So it as long as it's given within 2 weeks of the symptoms, it's very effective. It reverses the condition very fast. So here you have myelin breakdown. That's nice to know. We can skip the phases. Okay, let's go straight to manifestations. All right. So it starts from the toes and up it goes. So that's a nice acronym to, sentence to remember. That way it tells you that this is GBS. Okay, so it's ascending motor paralysis. What was the other one which we talked about last semester, which was descending, which was the opposite of Guillain-Barré?
Myasthenia gravis.
Myasthenia gravis. So myasthenia gravis started with the eye, right? Eye, and then involved the bulbar muscles, which are the muscles for speaking, swallowing, and chewing. So this one starts from the toes. But remember, the the diaphragm is a muscle. That's why it's affected by Guillain-Barré syndrome. So if it does reach the diaphragm now, the patient will require intubation. They cannot have spontaneous breaths anymore. The diaphragm will be so weak, it cannot support spontaneous respirations. Diagnostic testing is done by CSF. We do a lumbar puncture, we examine the CSF. They will have elevated protein but normal cell count, meaning that will rule out meningitis because yes, there's high protein, but then your white blood cell count is normal. And then of course we can do EMG here. The other test, which is electromyogram, is done to rule out other causes. So let's say maybe you have a spinal cord injury, maybe that's causing it. So EMG will help rule that out. So if the EMG checks out fine, because if it's GBS by the description I said, so let's say this statement here is the length, right? So if you put the needle here, put the electrical stimulus here in an EMG, it should normally reach here. If there's myelin here, so if you put the electrical stimulus here, of course it will stimulate muscle movement because that means the impulse travel normally throughout the neurons, right? So if in GBS there will be no such movement because there is absolutely no myelin functional myelin sheath already, meaning the neurons are there but the myelin sheath is gone. So therefore there will be no movement. So that is a positive EMG result. Whereas if you have a spinal cord injury, then that would be something else already. All right, how do we treat GBS? Again, as long as you seek medical attention within the first 2 weeks from onset of symptoms, there are two possible treatment modalities. One is IVIG, and the other is plasmapheresis. This really should say or, because we're not doing both. Because when they say here these modalities are IVIG and plasmapheresis, meaning we're using both, no, we can only use one or the other because they really have the same effect. So it's like, you know, using two band-aids instead of one. IVIG, the only thing here is it has a prohibitive cost. Immunoglobulin is sold by the gram, and the dose is based on your weight. So let's say each gram is sold at, I don't know, $1,200 per gram. So this let's say it's based on weight. So let's say the doctor orders 0.1 grams per kilogram. How much would that cost? It easily reach at least $20,000 per treatment. And you're not going to be given one treatment. It'll be a series of treatments in 2 weeks. So just imagine how much that will cost. Plasmapheresis is cheaper. However, we need a catheter because plasmapheresis is done. I mean, we discussed plasmapheresis last semester, right? Under myasthenia gravis?
Yes.
Yeah. Okay. So you know this is plasma exchange. So we go to the same machine, which works like a dialysis machine. So we need 2 needles, one to remove your blood, goes to the machine, and then returns blood to your body. So what we're removing is plasma. So we remove plasma and we exchange it for another person's plasma. Or plasma exchange can also be done mildly, meaning instead of having aggressive treatments by using plasma, we can also remove plasma in small amounts and just replace you with saline and then allow your body to replace the plasma naturally. The reason is, of course, these antibodies are in the plasma. That the antibodies that are killing your or destroying your myelin sheath is in the plasma. So this is one approach. You you remove the plasma, patient's plasma, and replace it with someone else's. So both, as long as they're given within the first 2 weeks, is very effective. See here, this will help the patient walk. Okay, meaning his symptoms are gone within 2 to 4 weeks. Okay, if the IVIG or the plasmapheresis is given soon, if they're given early. Okay, see, it's even worse here. So look at this. 2 grams per kilogram is the IVIG dosing. So that forget about the cost. Then it's way higher than what I thought it was going to be. Okay, of course, this won't mean that after you receive IVIG or undergo plasmapheresis that you'll come out walking and you're back to normal, right? You do have residual weakness here. So after the episode, you can walk, but you need physical therapy. So you're not done yet. So you'll have to undergo months of physical therapy in order to go back to pre-GBS levels. Any questions?
No.
Okay. The other management here is related to the treatment. Let's say the patient opts for plasmapheresis. So what were the complications of plasmapheresis again, if you remember last semester?
Hypertension.
Okay, number 1 is hypotension. What else? Think about plasma. So what is in the plasma? So therefore, if you remove plasma,
Clotting.
okay, the patient will have bleeding, right? Because we have clotting factors there. What else? What else is in the plasma? Do we have antibodies there?
Yes.
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 So, right. So the patient will have signs of infection or maybe at risk for infection after or during plasmapheresis, because we are removing not only the auto antibodies but also the good antibodies that are in the plasma. And it will be, the rest are related to the, you know, the site, the access, the IV access, like bleeding, infection, okay, related to the plasmapheresis procedure. Okay, diet. What do we do with the diet? So if the patient has speech involvement now, meaning the weakness ascended up higher, so the patient will be evaluated for dysphagia. So we'll have to modify the diet. And of course, the patients who are intubated, then they'll be on tube feedings. The rest of the complications are related to the immobility that results. Most serious, of course, are DVTs. And if unlucky, then they'll have a pulmonary embolism as well. And that's it. We still have 40 minutes though. We can do a lot with 40 minutes. Can we move on?
Professor,
Yes.
you said patients get plasmapheresis just like dialysis. Do they
Hello.
also can you hear me?
Not really.
Okay. I thought you said patients get plasmapheresis just like dialysis patients, right? So I was wondering, do they also get the access as well? Like the material accesses?
You mean what's it, a fistula?
Do you get it as well?
Hello?
Yeah.
Yes, some patients will have, but most of the time there won't be enough time because we need it right away. We need it like now. So most likely they'll have dialysis catheter instead of a fistula, because by the time we do a fistula, I mean, it's too late. By the time we wait for um, probably for other disorders, but not GBS. For Guillain-Barré syndrome, if you require plasmapheresis, if the doctor opts for plasmapheresis instead of IVIG infusion, you'll have to use a dialysis catheter. There's just no way for us to be able to use a fistula, um, you know, um, like right now. It takes several months or up to a year to
Right.
the fistula to mature. Yeah, I mean, this is an acute episode. Okay, let's just put it that way. So we need the treatment like today or tomorrow. There is a possibility that some of these patients never recover. Um, However, it's not Guillain-Barré anymore. Some cases do develop other forms of polyneuropathy, which is now um, something else. It's not Guillain-Barré syndrome anymore. Like the example is the former faculty member that we worked with. Um, we because she responded to treatment, so she had her diagnosis was really Guillain-Barré syndrome, because after she was given IVIG, she could walk already. No, she was on her feet and she started therapy, but I think 3 or 6 months, probably 6 months after her therapy, she was doing okay. She had another episode, and this time they checked her for, which is rare. You're not supposed to have a recurrence of the GBS, that's quite rare. And they discovered it was something else. It wasn't Guillain-Barré anymore. She developed another form of polyneuropathy. So she's now on uh, electrical wheelchair, a motorized wheelchair until today. So it's been 4 years now. While you guys are not